came here in person, thank you very much. And to those online, welcome and good morning. I have the distinct pleasure to welcome everybody to the 38th Kangos Lecture. And this is honoring Dr. James Kangos. He was a young man who went here at the University of Pittsburgh Medical Center for his residency. Before that, he went to Bucknell for undergrad and then went to Rutgers for medical school, was not only a pediatric resident here, but also an outpatient chief resident. And then he moved on to Connecticut, where he was a pediatrician and really championed those, foster children and making sure that there was good legal care for them and really revolutionized their care. He unfortunately had ulcerative colitis and passed away on his 35th birthday from colon cancer related to his ulcerative colitis. So this has been a wonderful endowment that we've had to be able to do these lectures and really continue to move the needle and push people to push research and better the care that we provide our patients so no one has to have the same situation that Dr. Kangos had to live through. We are very lucky today to have his family with us, and so we welcome them and thank them for continuing this wonderful lecture series. And I'm going to pass the mic virtually to his brother, Dr. Peter Kangos, who's going to talk a little bit further.
Well, good morning, everybody. I hope y'all can hear me. Thank you for this opportunity to honor Jim's legacy and memory this morning. Although I followed his tracks through college, med school, and pediatric residency, my perspective today will obviously be from a close family member. This year marks the 40th year since his death. As Dr. Deshevsky so eloquently states in the flyer, you could not ask for a more caring, unpretentious, and intelligent friend and brother. Jim had a huge affinity for the underprivileged children that he came across in his travels and education, including their families, multi-generation of families. He loved the working class Polish neighborhood where he chose to live in Pittsburgh. Getting to know the families in his building was important to him. They kept tabs on him and showed concern as to his whereabouts when he was late coming home, for example. He got a huge kick when he first saw the pairs of sneakers tied by their shoelaces hanging from the power lines. That was Jim. The onset of his ulcerative colitis came suddenly after a bout of mononucleosis in the spring of his fifth grade year. Now, in retrospect, thinking about his short life, until his tragic death, he demonstrated an amazing and remarkable acceptance of his disease and the long-term risks involved. He absolutely never complained about anything, except when a trip to the men's room interrupted a downhill ski run or an important inning at Yankee Stadium. In fact, as the years went by, I believe that his disease powered his dedication and pursuit of his interests and life in general. Acceptance and a calm confidence always prevailed over Jim. I also believe that was in large part passed down from our own parents who experienced more than their share of tragedy early in their lives. In so many words, Jim would say that he was very fortunate and that he was going to put his God-given talents to their best use. In his final years, he was very reticent to have a colectomy, as he was looking forward so dearly to the joys of marriage, someday having his own children, and his ever-present love of the outdoors. Jim got excellent follow-up care. He and our family were quite confident about that care. Dr. Shinya at Mount Sinai in New York City was one of his docs. He was the Japanese-born Mount Sinai-trained surgeon who pioneered the development and use of the colonoscope, and in particular, the surgical snare for polypectomy. He had a huge, long career and did an unbelievable 300,000 colonoscopies over that career. So, in spite of 24 years of follow-up by the most experienced people, he relapsed and was found to have an aggressive cancer, which caused his death 1 year after diagnosis. Just for everyone's perspective, the only available treatment for Jim's ulcerative colitis was Gantracin, sulfazoxazole, the generic, low modal, steroid bursts, and a milk-free diet. That was it. So today I am honored to support Dr. Sunseri's programs around IBD, particularly new patient education and ultrasonography. I'm very happy to be here for today's lecture. Thank you very much.
All right. Well, thank you so much, Dr. Kangos. Um, we're so glad to have you here with us. But without further ado, I want to introduce Dr. Michael Dolinger. He is currently the IBD Center Director at NYU. He did his medical degree at Albany Medical College and then got his MBA at Union Graduate College, along with his residency at Cohen Children's Medical Center in Long Island, New York. And then his fellowship he did at Mount Sinai, where he started learning his skills in intestinal ultrasound. And then he is actually the co-founder of the IU SCAN, which is the Intestinal Ultrasound Group of the United States and Canada. And so he's really leading the front here in the States to getting ultrasound to our patients. And I'm going to let him talk. So welcome.
Thank you. Switch this and yeah. All right, awesome. Thank you. Thank you for having me. Really touching to follow the story of Jim and what this lecture means. So I feel really honored to be giving it today. And especially to the trainees who are listening and the fellows in the audience. I learned all of this and what I'm about to talk to you about during my training, not as faculty, and not with so much kind of roadmap of where this would lead. So hopefully this kind of shows you where your career can go and how you can develop it. But I will also give the personal touch, because I thought Jim's story of that personal empathy and drive of having an illness really shapes the way you treat other people and families and the dedication. And so my wife has Crohn's disease and really inspires a lot of what I do or wanted to do. And learning this tool was a lot of that, and going to Mount Sinai, where I felt the best IBD care was given for training, was because she was seen there. And she still struggled with the disease and had many surgeries. And I felt like if she's seeing the best people, they don't have a lot of the answers. There's so much research. There's so much that still needs to be done, that even doing a small thing can impact the field and impact patients. And so that's still actually what drives me to this day, through and through. So this talk is about intestinal ultrasound, but it's more about how you change care in any field, not just IBD, in medicine today, which is quite challenging to do. These are my disclosures. And these are the objectives of the talk. I'm going to describe the role of ultrasound. You're going to see how accurate it is. You're going to see how we use it. And you're going to understand how to implement this tool and different tools and strategies across medicine. But I will say that's not really the important part. Everything I do is guided by patients and their experience. And this is what keeps me going. And I'll share a patient story to start and a patient story to end. And that will replace all the slides in between, because this is really all that matters. This is my patient, Tessa. She gives me permission to use this. And this is her story that she did for her junior year high school project. And this is her words, specifically when she interviewed me for her project about her disease, her inflammatory bowel disease. She says, "Every time I visit with Dr. Dolinger, he gives me an ultrasound, often with other doctors who are in training in the room. The ultrasounds allow him to look at my colon and see in real time how much inflammation there is. Being able to use ultrasound and see the information firsthand is groundbreaking, as it first allows the patient more control over their disease, and second, bridges the separation between a doctor and a patient. First, IBD is a disease that strips away any form of control or self-security. When I was first diagnosed 2 summers ago, I remember my mother staring me in the eye and telling me she didn't know what foods I should be eating. I remember opening the refrigerator each week, feeling hungry, and desperately scanning the shelves to see if I could eat any of the even simple foods I once did, like a slice of bread or a spice. I remember gazing at the aisles in the supermarket, deciding whether it was worth the trade-off of eating something I wanted or being in pain. I would wake up some mornings with my stomach killing me, and I would constantly be experimenting with medications to the point of no avail. However, with Dr. Dolinger, who listens to and believes me, along with his ultrasounds, I have the opportunity to understand my disease, allowing me a form of control over my body. In addition, the ultrasound process bridges the divides between a doctor and a patient. When doctors use a tool that promotes trust, it demonstrates a doctor prioritizing their patients as they involve patients instead of blindly leaving patients out. When Dr. Dolinger mentioned that one of the most exciting moments is when he turns on his lights and sees people crying after conducting ultrasounds, I can understand this reaction because of the way ultrasounds offer a complete new form of care that strengthens everyone involved. I'm so grateful to have the opportunity to use ultrasounds, and I hope, as Dr. Dolinger does, that one day everyone will have this tool too. So that's it. That could be the whole presentation. I could show you research after research and how we're impacting the field, but this is where the impact is. It's with patients, and it's giving them control and a shared understanding about their disease. And this could apply to any chronic illness. When you're in a room, patients really want to be seen and heard and listened to and felt like they actually have power in the decision-making process. And this is what this tool does. I equate it to being in a confessional. I often do it for other providers' patients. And when you darken the room and put your hand on a patient for 10 to 15 minutes and are just talking to them as you ultrasound and explaining things, we do this for elderly, we do this for 2-year-olds. They start to tell you things 5 minutes in this dark room that they don't tell their provider. And it builds this level of trust, and it's a pretty magical experience, and actually inspires me every day and reinvigorates me. You know, when you've had long days in clinic or endoscopy or inpatient units, these experiences still happen every single day for me. So, okay, taking a broader view, why is this actually changing management? I know it's coming here. There's an ultrasound machine, and Whitney completed the training. So this is coming to Pittsburgh and really will revolutionize IBD care so fast. I've seen it happen at so many centers. So why is this happening? And I recognize many people in the room don't know about inflammatory bowel disease in detail. So this is a chronic illness. We tell people that the immune system causes inflammation in the gastrointestinal tract. And most of that inflammation is occurring under the dotted line when there are no symptoms. And that inflammation reaches a level that then causes symptoms, but it's often too late. And it goes undetected. And we calm it down with medicines, anti-inflammatory approaches, whatever that's going to be. But then there's often still subclinical inflammation. We don't completely heal, but we say our patients feel better, so we must be doing a good job. And we are wrong. And then all along that happens, fibrosis, scar tissue builds up. And that leads to surgical complications, increased risks of cancer, dysplasia, all the things we worry about that we can prevent if we have a strategy that's a really, really smart from the get-go. Then you heard about some of the older medicines from Jim's time that we don't really use anymore that existed then. And we have so many medicines now. But are we any better at caring for colitis and Crohn's disease in 2026 than we were 30 years ago? I would argue yes, but we're only a little bit better. About 30 to 40% of our patients achieve sustained deep remission and healing of their intestines, and they're able to maintain that. That's pretty bad. I look at this and I say, if I flip a coin, the chance that I will have healing, no surgery, no complications in my life with IBD, avoid hospitalizations, steroids, is pretty low. So this means we can do a better job. To accept the status quo where we are and caring for inflammatory bowel disease would be a disservice to our patients. If you're not changing the way you practice every 6 months or so, you're really falling behind. You should be trying to push the envelope, do something different, because if you think you're good at your job, you can just look. If you have 100 patients, probably 30 or 40 of them are not doing perfectly. There are a lot of ways we can change that. We can do better in many areas, but I'm going to focus on one area today, and that's non-invasive monitoring with ultrasound. So when we are able to treat patients, we are often seeing them somewhere along this curve of their disease progression. We don't know where they are along the curve, but when we see them as children, it's often earlier than when they're adults. And we have a window of opportunity where we can treat them before scar tissue has developed, before they have dysplasia or other cancer risks, and we can alter their progression and prevent these complications down the road. We can implement, once we have an effective treatment and we get it right, a tight control monitoring program to actually see their inflammation. And even when they don't have symptoms, make sure there's nothing going on in their intestines. We have experts that tell us how to do this. And I would argue the experts are not that good at telling us how to do it. So we again can do better, but this is the all-knowing guidance from everyone in the field of inflammatory bowel disease. It's called the STRIDE 2 consensus. This is what all experts refer to. So you take a patient with active inflammation, you want to make them feel better first, that clinical response. You then want to put them into remission where they have no symptoms. Their biomarkers should normalize, inflammatory markers, CRP specifically. Then in kids, which they include in this consensus, they want to normalize a stool biomarker called fecal calprotectin, and they want to make their growth velocity normalize. And then ultimately, within 1 year, they want to achieve healing of the inner lining. So where does that come from? That comes from a study that was done, which randomized patients to care that just goes by clinical symptoms. If we give you a medicine, do you feel better? Great, we're not going to change care. Or tight control, clinical symptoms and biomarker with a stool test, that fecal calprotectin. So even if you feel better, if your stool test is still elevated, it means you probably have inflammation. We should change care, escalate therapy. Patients in the tight control arm here were more likely to achieve healing. This is that endoscopic healing, 45%, than patients who are just managed with clinical symptoms. And you could say, that's great. Tight control is better than just following symptoms. But I would say it still sucks. More than half of patients in the tight control arm do not achieve healing. So even with our best monitoring strategy, patients in a trial who are doing rigorous stool testing, 45% of them achieve healing at 1 year. Again, if you're meeting a family in your office and you were to say, well, there's a 45% chance we can do a good job for you, they would be upset at those numbers, right? So we can do better, but this is where the guidance comes from. And then what if we actually heal you? Does that mean we impact the long-term outcomes? This question was also answered in a randomized trial. This is all adults. But you can see the blue bar is patients who achieve the healing, and the red bar is patients who do not achieve the healing. And this is if they go on, and you could see the days in the bottom, so out to 2,500 days, do they have disease progression, meaning hospitalizations, surgeries, complications, steroids? So if we heal, do we actually prevent the things we're worried about? And you could say, yes, the blue bar is better than the red bar. I think anyone could take that without science, but I would argue that even if we achieve healing, more than a quarter of those patients still go on to have disease progression. So we only achieve healing in less than half of our patients. And for those patients that get there, a quarter of them still go on to have disease progression, having the same complications as if we didn't achieve healing. Again, we can do better. And the message I take from this expert consensus is that tight control monitoring in its current state is ineffective to achieve treatment targets, but that's really in its current form. And I had a lot of time to think about why this happens. And if you take your doctor visit for any specialty, I think there's often a kick the can down the road mentality. A patient comes into the visit and they tell you about their symptoms. Very rarely does a physician act on those symptoms to make them feel better and change care immediately in that visit. We order tests, we order imaging, in GI we order scopes, and we will then figure that out. That takes time to schedule. That could take time to result, We'll call them a few days later. Imaging's a couple of weeks later. Scopes are a couple of weeks later. And when that happens over the course of a chronic illness of 40 or 50 years, those weeks add up to years, and that leads to that chronic damage. And this can be applied to any specialty. It's really, what is the problem, I think, of chronic disease management is this kick the can down the road mentality. And then why we really need to change care is, why do I need to come in person to a visit if you're not actually going to change care? How often does a physical exam actually change the management and disease course for patients with chronic illness? I would say almost never. And it's the same reason there's not a lot of people in here and there's a lot of people listening online. It's the same at our institution. It's much more convenient to do things via telehealth if you can get the same information and then be, on your way to work or do other things. We should see patients via telehealth. Why do they need to come into the office? Especially when we could do all of those tests, the stool, the labs, they can be done at home. We can do symptom scores on our phone. We could do everything via telehealth. If you're not doing something meaningful besides a clinical exam in the office, we don't have you come into the office anymore. This is where care is changing and will continue to change pretty rapidly for the future. So that's where ultrasound comes in. This makes in-person visits invaluable. Patients do not have to prep. They do not have to drink anything. We can put the probe on and we can know all that we need to know to make every decision without any other test within 5 minutes. And I know that sounds kind of crazy and it sounds like I'm just spewing whatever nonsense, but I will tell you it is true and it happens all day, every day. So this is inflammation. You may have never seen ultrasound. You may have never seen Crohn's disease, but patients, kids, families, everyone understands it very quickly. Inflammation anywhere in the body is swelling. In the intestines, it's thickening, which is swelling. So this is a thickened small intestine. And there's increased blood flow. Red and the blue is like a bruising. They're not bleeding, but it's bruising. So inflammation in the body is swelling and bruising. And this is a hot, active, swollen small intestine consistent with Crohn's disease. This isn't subtle. And this isn't like a dramatic case that we see. This is what we see all day, every day for a patient who is asymptomatic, feeling completely well. This is Crohn's disease. This is what it causes. It takes, we're always training people to do ultrasound, which I'll talk about. But if I do this, maybe 10 to 20 seconds, it will take me to get this image. And we know everything we need to know, that this patient's medicine isn't working or they need a therapy. That's it. We don't need lab tests. We don't need a scope. We don't need MRIs. We don't need CAT scans. Nothing. It's the same for ulcerative colitis. This is the colon. In med school, I was taught that ulcerative colitis is a mucosal disease. It's limited to the inner lining. That's one of the differentiators between Crohn's disease and ulcerative colitis. That is factually incorrect and completely wrong. Actually, every ulcerative colitis patient has transmural disease. It is never limited to the inner lining. And actually, the layer involved in ulcerative colitis is not the mucosal layer. The driver of inflammation is the submucosal layer, where that gray layer here, where the red and blue signal is tied. This is the colon, and this is not Crohn's disease. And it's thickened, swollen, just like Crohn's disease. We only know this because we started doing ultrasound. We don't do MRIs and CTs for colitis. And when you scope, you look at the inner lining, and here you have ultrasound showing the same thickening, swelling, surrounding inflammatory fat. I'll walk you through a simple real-world case of how this goes. So a patient comes in with abdominal pain. They don't have a diagnosis. They have a long story, right lower quadrant pain. It's happened over the last 4 months. It's intermittent, but pretty much every day. Can be vague. They can't really pinpoint it. It ranges from 1 to 10. There's decreased appetite. There's weight loss. But they're not really having any diarrhea, but they're concerned that, they're having nausea and vomiting. With the weight loss, the pain, it's been going on for 4 months, IBD's in the differential. There's more to the story. There's not really fevers. There's not joint pains. There's not really anything remarkable. Goes to the pediatrician in February. She feels fatigued. They think it's consistent with mono and says, this will get better. It's probably viral. She doesn't really get her menstrual cycle anymore, which stopped and was regular. And there's a family history of Crohn's disease. You can go to any gastroenterologist and they will say, you probably may have Crohn's disease. This is on the differential and we need to do tests. We need to do stool tests and we need to do imaging and we need to do scopes. We stop the patient within 10 minutes, letting them tell their story. We say, let's do an ultrasound. And right now we will be able to tell you if you have Crohn's disease or not. And this is that patient's ultrasound. Their whole colon is normal. and you go to the small intestine. And again, you may have never seen ultrasound, but there is an inflamed, swollen, thickened terminal ileum piercing through inflammatory fat over the psoas muscle going across your screen here. And we look at it in cross section. We can see it. We show the family. There is nothing else, not TB, not infection that causes this. There's no differential diagnosis. This is Crohn's disease. Within 10 minutes of a new consultation, the diagnosis is made. It shifts it from, well, it could be this, it could be that, we should get a scope. No, it's definitive for the patient. They don't have to drink anything. They then wonder why they have to get a scope. And I tell them we can't get meds through insurance and approvals otherwise if I just go off crazy and just diagnose you by ultrasound. But that will actually change too. And we're working on changing it, especially for younger kids, because what if we scope them and we don't reach the terminal ileum? That happens. And then what? Do we get an MRI and is that better? It is not. So this is it. This is all we need to diagnose the patient with Crohn's disease. And you can see here that same hyperemia I showed you. It's a different patient in the other video, but it looks the same. It's all about pattern recognition for learning ultrasound, thickening, swelling, increased blood flow. So it really changes the visit. Then we're shifting this new patient consultation to an hour-and-a-half visit. We're explaining to the family, they're crying. They now have a chronic illness. They're not retaining any more information that I'm telling them about their disease. And we're setting up multiple visits and we've changed their life. We're not kicking the can down the road anymore. We are really shifting things up immediately into the visit just by placing an ultrasound on the belly. It's not a magical ultrasound. It's not a different tool. It's the same thing found in every clinic around the country. It's just the technique. So what is that technique and how is it different? So this was not done in the United States before 2019 when I learned it. And it is done like a colonoscopy, systematic approach, no matter where your symptoms are, what your disease is. We go around the intestines from distal to proximal, starting in the rectum and sigmoid colon and working your way around the descending colon, transverse colon, ascending colon, and then the terminal ileum. We don't miss anything, and we do it like a scope. This is my colleague, Noah Cleveland in University of Chicago. She's the second person to do this, and this is what it looks like in real time. We now film this for clinical trials, which is implemented in every IBD clinical trial going forward, but this is what it looks like doing it in real time. Simple abdominal ultrasound, just in a systematic approach, going and not missing anywhere along the colon and small intestine. I've heard radiologists say, well, there's bowel gas. You can't see the intestines on ultrasound. Actually, the air in the intestines help us. That is also false. You can see everything. I would argue they've never done it. If that's what they're saying, they may have read it in a textbook, which that's what it says in textbooks. Ultrasound is the only tool that visualizes the bowel wall layers. It goes white, black, white, black, white, like an Oreo cookie, and you can see the layers of the bowel wall. MRI and CT scan do not have the resolution to be able to do that. So we've learned that the pathophysiology of IBD is actually driven by different layers, the mucosa, the submucosa, the muscularis propria, more than we've ever learned from pathology or surgical resection in just a short period of time. And I can go over all the advantages compared to other tests, but it's really simple. It's real time. There's no fasting. Kids can eat, have a lollipop, have a sandwich during it. They can watch on the iPad. There's no prep. There's no radiation. It's accurate, repeatable, and reproducible. And who is this for and when should we do it? I would say all IBD patients should get this whenever they're coming in person. Again, once you start doing it, you can never unsee what you were doing again. At diagnosis, to monitor treatment response, to detect complications for our special populations, pregnant IBD patients, post-operative, and then all children, all elderly, anyone with a comorbidity should go ultrasound monitoring as their primary modality. And when should we do this in IBD? Every phase of care. When we're starting treatment, when we're deciding how severe the disease is, when we're seeing if that treatment's working, not within months or years, but within weeks or days, and I'll show you that. During maintenance, when they feel good, making sure there is no more inflammation. And if there is, doing something about it. And then when they have flares, because we're not all perfect at getting our patients under control, monitoring them with ultrasound and reestablishing control and switching meds. And then it's about cessation or stopping therapies. Patients, when you prescribe them an immune therapy and tell them they have a chronic illness and this is lifelong, the first question they ask is, when can I stop that therapy? And actually, we can stop therapies, but you need a monitoring strategy and you need to be able to say, oh, you're on steroids. It's the same thing. We're tapering off your steroid. How are we going to know that the medicine we have used makes it so that your bowel inflammation is not going to come back? We're going to monitor it with ultrasound. Patients get that. So we use it in all these different phases. But most importantly, there's a study done that shows that ultrasound enhances shared understanding. This is a randomized controlled study of patients who got ultrasound-driven care and non-ultrasound-driven care in the UK. And patients who got ultrasound-driven care knew more about their disease. They helped understand where their symptoms came from, and they felt they could make more informed decisions about managing my IBD. One of the biggest arguments I would get is, well, this is going to add time to the visit. How are we going to do this within a visit? And I would argue it saves time. All the conversation is shifted up and it's changed by ultrasound. All of their questions are often answered by seeing the ultrasound images. And it's picture and video is like 1,000 words. I would argue it's worth way more than 1,000 words. This really allows patients to understand that they need treatment or treatment's not working. How do we know it's accurate? We actually studied this. So we're able to show how do we see that this translates to ulcers, erythema, edema, what people know. So convincing people to change care is not easy. You have to show them that it matches the gold standard. And that for us is colonoscopy and our endoscopic scores. I won't go too much into the data, but this shows that ultrasound and just monitoring the thickness is 95% accurate and beats, and these are other ultrasound scores, beats CRP, calprotectin, and symptoms by a mile. And then how do we know we can monitor response and when should we look? So this is a patient who has ileal Crohn's disease, thickening, increased blood flow. We'll tell you, oh, we should look in 3 months. We should look in 6 months to know that it's healed. This is 3 weeks later that inflammation is gone in the small intestine, where people say it takes longer to heal. If you get a therapy right and you catch it early in that chart that I showed in the beginning, you can heal very early. And we know this patient's going to go on to do fine and prevent disease progression. We actually studied patients, comparing everything. We took patients with ileal Crohn's disease, so the small intestine involved, and followed them at baseline with ultrasound, symptoms, and CRP. We repeated everything at week 8, 6 months, and then scoped them all at 1 year. And we were able to see, does ultrasound predict healing at 1 year if we see early changes? And is that better than symptoms or CRP in kids? And we were able to show that a 20% decrease in bowel wall thickness at week 8 was 100% predictive of healing at 1 year endoscopically. So that family who's worried, who's concerned my child has a new diagnosis, we tell them, okay, we started treatment 2 months later, we're on the right path, but actually just being on the right path, we know with complete certainty that your child's going to achieve that complete healing and be fine. That reassurance we can give families is invaluable. And again, more accurate than symptoms and CRP. We did this with ulcerative colitis and found that similarly, that it is more accurate than symptoms and calprotectin. Calprotectin was actually very accurate. So if you don't have ultrasound, doing a calprotectin at week 8 and getting a value less than 177 was very predictive of achieving remission at 1 year. But the most predictive was achieving normalization on ultrasound at week 8. We use this in the hospital for all of our patients who are admitted with acute severe colitis. We're not waiting until week 2, week 4, week 8. We're doing this every day. And you can see the changes every single day. So this is infliximab for a patient with acute severe ulcerative colitis. And again, you may not see ultrasound, but this is over the course of 48 hours. That bowel wall that was thickened is now healed and the layers are restored to normal. We know that patient's not going to have a colectomy. We don't have to worry. We don't have to involve our surgeons. We know that this patient's going to be completely fine, no matter what their symptoms are, just by putting the probe on their belly. And we do this all the time. Here's another case, just showing the bowel wall from thickening to healing over the course of days, not weeks, not months, but days. And it's pretty magical for a family who's worried about their child having a colectomy, certainly doesn't want to go surgery. And that really shapes the whole decision-making. Conversely, we see when things are worsening, and we know if that patient needs surgery, and it helps us convince them that they do. So ultimately, there are new guidelines coming out this year, the STRIDE 3 guidelines, and they're going to incorporate new things. And that is for the first time with ultrasound data that we should be targeting the whole wall, not just the inner lining. And from this, we're actually going to have a lot of machine learning about how the bowel wall layers contribute to the pathophysiology of IBD, and ultimately will allow us to develop new studies that hopefully lead to a cure and being able to prevent this disease before it ever starts. That's not my role, and I can't do any of that stuff. I can do one thing at this point, and it's teach ultrasound and get this to patients. It's really not, you learn quickly. Once you see it impact patient care in your own practice, you learn that you want to bring this to all patients, especially when you have a motivation and a need. to do that. And I feel like that's the one thing in life I can do at this point, is get this to all patients. But it is really hard to convince people to change care and to get that across patients globally or nationally. So this is where I spend all of my efforts now, is on ultrasound education and training, specifically within IBD. And this isn't just teaching people to pick up a probe and you may learn it for 2 weeks in med school. This is really doing it as the sole decision maker for patient care and IBD, making life or death decisions for some of these kids. So we had a grant from the Helmsley Charitable Trust to implement this training across North America, which finished last year. And that allowed the formation of a nonprofit organization called IUScan. And through this, so Noah Cleveland's the second person who learned this at University of Chicago, who I taught. Michael Winter at Dartmouth is a gastroenterologist, the third. Kathy Liu is from Calgary. And then David Rubin and Corey Siegel, who I saw actually gave this talk maybe a decade ago, is on our board of how to implement this, a tool across every IBD center so it reaches every IBD patient. That's the mission of this organization, to educate and train trainees, gastroenterologists across the United States and Canada to implement this into their practice. And we get information out there. That's one of the other things. You learn you have to do things across different aspects. And figuring out how to get information to people. Do patients read publications? Do providers read publications? Do med students, do residents, do fellows? They do not. No one reads the literature in detail. People will go on, they will look at social media, they will read websites. So we created a website, and you say, how do you do this? We had no money as a nonprofit, we had no funding, and we had no one to build a website. So I learned how to build a website. So I built this website in my free time at night as an attending. And it shows when we have events, but most importantly, there is a provider directory. So building in where you can search your state and see, if you're a patient, where is ultrasound being done and what providers are doing ultrasound. And this page is visited so often. And I feel like this is a simple tool we built to get information out to patients. How do we get information out to providers? You have to say people want to learn, but there's still so many people who have no idea what this is. We have a webinar that reaches globally 60 physicians every month on the second Tuesday. And we started this thinking maybe 3 of us will show up and have coffee and talk about ultrasound and cases and how to implement this. And we promoted it on social media and just said, come. And eventually 20 people turned into 30 people, turned into 40 people, turned into 50 people, turned into 60 every single month. And we have cases submitted from all over the world. And we talk about just how do you get this tool into clinical practice? There's no egos. I heard that Jim was unpretentious. This is about that. This is about just spreading a tool. How do you help people along that journey? And so it's nice to have a different initiative. So just a simple monthly webinar. Presenting to different physicians, even if they want to learn it, they would say, well, this doesn't make money. This doesn't get RVUs. We can't implement it into practice. Because it's nice to want to do something for patients, but I would argue most hospital administrations around the country, I now get the pleasure to speak to all of them, they don't really care about patients and what's best. They care about the bottom line and dollars. And if you really want to change care, you learn that you need to make the case from a business standpoint, why this is not only impactful from different revenue streams, but how to implement this and get RVUs. And then when you do, you have to get people to listen to that. So we created a business blueprint with a downloadable business plan. Most physicians don't know how to make business plans. And we created this on our website and is downloaded all the time. So you learn that changing care actually is not just doing research and doing this and showing it's effective for patients, but it's educating, it's hand-holding people, it's working with administrators, it's working on the finance side, it's doing things at night on your own free time. There is nothing you can do that is different than this multi-pronged strategy if you really, really believe in something that will change care. And then I think the current way of training is not very good. The international standard in which I learned has so many bottlenecks. We can't meet the demands. We've done a good job of educating people and saying you should learn ultrasound. We have 5 to 6 applications for every 1 spot. And I was saying last night at dinner that every time someone is rejected, all that hate and anger comes to me as if I am the sole person who is responsible for all the global training applications and selection process, which I am not. But we need to modify it and make the case that we need to make this more scalable. So learned how to build e-learning platforms to take these expensive introductory courses that cost thousands of dollars and shrink them from 2 or 3 days to 1 day, or even now a half day. And then take people who are learning at centers and how do you standardize it, actually give them a radiology platform where they can review cases and measure the bowel wall thickness and learn this. And no money to do this, no one saying how to do it, but just reaching out and figuring out how to code on a computer, currently trying to figure out how to make this into an app that you can do on your phone. And again, it's not about waiting for someone and getting a grant and applying and putting it on your CV. None of that matters. You don't even think about it. You just do. And if this is something you feel passionate about, the rest, all the pieces will fall into place. And I will end with one more patient story. And this is hanging in my office. So when patients come in, they see this cartoon. And this is the most moved I've been. You'll see the similarities from the beginning story. So this is a patient of mine who travels from Virginia to see me and started to come to see me when I was at Mount Sinai. And she says, I was 11 when I was first diagnosed with Crohn's disease. At first, I didn't understand what it meant to have a chronic illness. She draws, she's going to have this condition for the rest of her life. And she's upset. Says the first summer after being diagnosed, I didn't eat any solid foods. I was on a liquid-only diet. Afterwards, I started on a strict diet, which I still follow to this day. It was hard at first. And it shows her mom saying, baby, you know you can't eat that. And she draws herself crying, saying, I know, I'm so sorry. And throughout this journey, there have been many highs, your levels of inflammation have gone down, and many lows. It hurts so much drawing herself alone on the floor in her room at night. And she says, I started on Humira in August 2021 through injections into my abdomen. It helped a lot, though I had a flare a year later in August 2022, and she felt hopeless. She says, when will this get better? And then 2 weeks ago, she comes to New York to see a gastroenterologist who specifically does ultrasounds in pediatric IBD patients, which is a new concept he is working to normalize so that kids won't have to go through frequent imaging procedures. And from him, we received incredible news. Your small intestine is completely healed. Though there's some scar tissue and permanent narrowing, if we prevent active inflammation, she understood this concept that we try and teach our fellows. If you have scar tissue, but you prevent more active inflammation, you won't need surgery because it won't further stricture down to the point of blockage in the future. And she was so happy. And she has this whole kind of look back at her disease with over the last couple of years where she says, I'm not in complete remission yet. She understands that concept that she doesn't had healing completely, but she still has to be careful to maintain all the progress that has been made. And she has hope for a better future. She then realizes she has to thank all the people in her life who have never left her side. And she says, I'm truly blessed to be so loved. And even though these past years have been so difficult, they are also so beautiful. One of the most valuable things she's learned, and I'm still learning, is that you can't see the rainbows without the rain. So it's okay to have hard times because they will always pass and the light will always shine through. So I have this hanging in the office because it really shows, again, all the research, everything we're doing. The patients, they just want to understand what's going on with their own body. And once they do, the light bulb clicks and a transformative experience happens. And that's happened for me as a physician at this point too. So I will leave it there, open it up for any questions, and really thank you for having me.